My earliest memory of wanting to be a doctor was probably when I was 7. I received a lot of inspiration from my grandfather, who was a pediatrician, and he had a really inspiring, rewarding career, and I wanted to be like him. First year of medical school is a lot of studying. I'm in this library most of my day. I generally wake up and I go to class from 8 to 10. We have a lecture where we learn basic science material. And then we usually have a small group session to learn how to take a stranger who has a constellation of different symptoms and then put them together in a sort of cohesive map and figure out the most likely medical problems that might have brought them into the hospital. And then for about 6 hours, I'll review yesterday's lectures, I will review today's lectures, and then I will repeat today's lectures.
Preparing the Future is a program that we put in place to train future health professionals to routinize, normalize, and integrate HIV testing into their future clinical practice. This program works with faculty and students from the University of Maryland School of Medicine and School of Nursing. We're training students in HIV testing both didactically and practically, meaning that they're getting the classroom training, but they're also having the ability to be in the community or in healthcare settings testing people for HIV under the mentorship of the Jacques Initiative.
I've had a really positive experience with the Jacques Initiative. It's really exposed me to healthcare in many different perspectives. So first of all, there's the patient interaction perspective. I've got to meet a lot of different people, and so I have a sort of firsthand experience with giving them HIV testing and counseling, but also from multidisciplinary aspect of healthcare. I've got to meet with a lot of other students in nursing and social work and law, as well as other professionals, and learn from them and share ideas and share experiences, and that's been really special.
Very quickly, even the laggards among us, about the value of practicing in a team. And when you put that all together, you get a well-educated patient and family, a well-informed patient and family, and yes, predictably, although much more research is needed, better outcomes. Who's in the room tonight? How many of you are nursing students? Good number. Medical students? Terrific.
In medicine, we're sort of focused on the science or the molecular mechanisms behind a disease process, whereas somebody in social work might be more interested in the psychosocial dynamic issues that the patient is forced to grapple with HIV. And neither one of those is more important. They're both equally important, and they both play a pivotal role in delivering care. So the case conference was a few individuals were presenting unusual cases to a diverse audience in an effort for the audience to help dissect and to learn from and to strategize for how to deal with those cases in the future. I was a part of a team that tested a patient who was HIV positive.
Went to the University of Maryland Medical Center emergency room for suture removal. She had some scratches on her face, which was a result from a fight with a friend. She had no past medical history. She was not receiving long-term care.
And she was extremely upset by this. And she was somewhat surprised because she was in a monogamous relationship. She was married and she had children. She felt like she didn't deserve this, and this wasn't how she behaved, and she didn't deserve something like this. It was a real struggle to have her calm down and walk to the Jacques Initiative and speak with professionals about how to go from there. Some of the preconceptions that I had before beginning the Jacques Initiative program was that certain groups are at higher risk for contracting HIV, and while that might be true from an epidemiological perspective, the truth is anyone can get HIV. And so I think that we need to sort of leave our biases at the door when we're testing and counseling and interacting with patients, because anybody can get HIV.
So they come with kind of these broad types of opinions because they haven't had the individualized experiences. And so as they have participated in PTF and been at the Jacques Initiative, they've really been able then to cut through a lot of that. They've been able to see that each case, each individual has to be taken as they come.
After working with Jacques Initiative, and that I realized what stereotypes I did have, and I wasn't even so aware of them until they were broken. Also, I got HIV tested. I realized I'm just as at risk as anybody else living in the city of Baltimore.
I think I learned a lot about self-reflection and realizing my own personal biases, working in the emergency department with a completely new demographic from what I grew up in, exposed to a lot more diversity of race, of culture, and just realizing the personal biases that I brought into the emergency department.
I was like many of my classmates and had certain ideas about HIV, a basic knowledge, but still had the stereotypes, and I'll admit it, still the bias of identifying people of certain stereotypes as more of a possibility or more of a risk.
I personally feel empowered to speak with people about their very sensitive personal lives and subjects that are hard to speak about. And I feel that I'm going to be able to use those skills not only in my future as a physician, but also in my life and personal relationships.
I can look them in the eye and say, like, this is going to be okay. We're going to take care of you. I know who can help you.
I don't think I was really aware of what a huge problem HIV is here in Baltimore, and I've always been focused on going overseas to work on HIV/AIDS education and prevention, but there's such a need for it right here in Baltimore.
As a physician, I will absolutely be exposed to HIV-positive patients and people whose lives have been affected by HIV and AIDS. And this has really, it's put a face to the disease. It's not some scary disease anymore. It's not just numbers anymore. It's people that I've spoken to, that I've touched their lives, and I've made friends through this. And throughout my career as a physician, this is something an experience that I would have never gained elsewhere. And it's something that will really stick with me when I see patients with HIV and AIDS and really any other chronic disease, because that's all that HIV is.
It's a curriculum that starts in the classroom and takes you to the rest of life. You get a new kind of HIV education in the classroom that you probably haven't heard everything about before, and then you get out in the real world and you implement that practice.
Service learning is a model whereby we, as the School of Nursing, form partnerships with communities that we're serving, and simultaneously offering opportunities for our students to gain much needed knowledge and skills, which is to say that it's not about simply academic exercises for the students, it's really a process of serving the community as the students learn.
This program is about training in its initiation through medicine and nursing, healthcare professionals who will routinize, integrate, and normalize HIV testing. The history of HIV is filled with them and those people disease. The solutions are related to we and us.
There have been a number of transformations. One of the most important is that they have obviously learned some new technical knowledge and skills in terms of how to test, how to prepare the testing equipment. But more importantly, in my opinion, is they are learning how to relate to patients, clients in a different way.
So we feel that if we get to these healthcare professionals before they're in practice, that we're actually creating a new culture.
Every university health system should be doing something like PTF. It is a model that should be, if you're a university health system here in this city, anywhere in the country, you should be doing the PTF model in regards to HIV or any other major public health issue confronting your community. But I also think it's a model here within this city that can also be held up as to how do we take these citywide strategies, national strategies, and how do we really get the stakeholders and the appropriate people to really begin to actualize and do the work to make them happen. So they're not just strategies that we talk about or put out on paper, but that in 3 to 5 years we are getting to zero.
So when you hear the debate now about an AIDS-free generation, it's not really a pie in the sky. It actually is, we have the tools that within a decade or two, you could drive this epidemic all the way down by early diagnosis, effective engagement in care, and as a consequence, reducing the community viral load to a point that it can't sustain epidemic transmission. Now that has to be coupled with a comprehensive prevention program, comprehensive engagement of education, behavioral education, but early diagnosis and treatment are also fundamental to a comprehensive prevention program. So when we talk about this concept of diagnosis or testing and treating, that if one was to do that for everyone that was HIV infected, the epidemic would in fact, stop.
When you don't make innovative moves like this program, Preparing the Future, what we get is what we have. And what we have is an epidemic in crisis proportion, where we consistently have 45 to 55,000 new infections in the United States. And so when you don't have programs like this that are impacting professionals, then there is the stigma, there's the perpetuation of discrimination, though silent and many times unrecognized, still devastating. And so this program begins to sensitize us that we are part of the solution to make a change that's necessary to get to zero.